Hi, good afternoon. My name is Anna, and today I'd like to share with you a case that we got to see in clinicals. This is a case of a 37-year-old male who presented 2 weeks ago seeking treatment to quit alcohol while avoiding alcohol withdrawal symptoms. He shared that he works in construction and has not missed work, but is worried about the long-term effects of alcohol on his body. He also shared that he has been drinking to the point where he is drunk every day and does not get a hangover. He drinks mainly at night before going to sleep. He drinks 40 ounces of mixed commercial drinks and 2 vodka shots, uses marijuana 2 to 3 times a week, denies other drug use, and as part of his psychiatric history, the patient used the antidepressants from 2013 to 2016. He denies history of past hospitalizations, auditory or visual hallucinations, or suicidal attempts. So today he's back in our clinic and he is here for a follow-up, including lab results. His kidney function test is normal. AST and ALT enzymes are elevated, and his urine test shows alcohol and marijuana metabolites. His last alcoholic drink was last night around 9 p.m. and he denies anxiety or depression symptoms. He also denies suicidal or homicidal thoughts. For the intake, I asked questions related to his medical history, psychiatry history, and family medical history. We also spoke about the safety questions and substance use. This patient already is worried about his alcohol use. So I didn't have to do the screening tool to assess for alcohol use, but on other patients I will use the U.S. Preventive Services Task Force recommended screening tools, which are the audit alcohol use screening and the single alcohol screening question to assess for heavy drinking days. So the differential diagnosis, all this patient does meet the criteria for alcohol use disorder. In the last 12 months, he has had impaired control of his alcohol intake as the patient uses more alcohol than intended and has been wanting to cut down and is unable to do so. He also has a tolerance, as seen with markedly diminished effect with continued use of the same amount of alcohol. As far as other mental health conditions, well, he denies any anxiety or depression symptoms. However, we know that he at one point was using antidepressants, and we also know from literature that alcohol use disorder can coexist with other medical and mental health conditions. So in the course of the treatment, we might learn more about this patient and find other mental health conditions. For as part of the treatment plan, alcohol use disorder treatment can be done with psychotherapy, pharmacological treatment, or a combination of both. And the FDA has approved naltrexone, acomprosate, and disulfiram for the treatment of alcohol use disorder. Before choosing a medication, there are a couple of things that we need to have in mind, like the patient's preference, contraindications, and side effects. So this patient already mentioned that he is concerned about alcohol withdrawal symptoms, and and that is something that he mentioned in the initial consultation with us. Um, Now we know that his enzymes are liver enzymes are elevated, so we have to have that in mind too. Um, so um, going back to the approved medications for alcohol use disorder, this sulfiran treatment, um, when using the sulfiran, it is required 12 hours of no alcohol drinking. Okay. For naltrexone and disulfiram, these medications are metabolized in the liver, and that is why my preceptor and I, we agreed that we could use a compressate 666 milligrams, 2 tablets 3 times a day. This medication is preferred for patients who are highly motivated and helpful for patients who with liver disease, as this medication is not metabolized by the liver. This medication is actually metabolized in the kidneys, and it doesn't have to have any alcohol abstinence before we begin treatment. It is recommended, but not required. And for psychotherapy, the therapy recommended is CBT, or cognitive behavioral therapy. The elements of this psychotherapy are a focus on changing thoughts and behaviors, where the therapist guides and teaches new skills. This psychotherapy is structured with sessions and homework, and it's best when someone is ready to make changes, unlike motivational therapy. And this patient, it is ready to make changes. CBT for alcohol use disorder helps individuals understand the link between their thoughts, feelings, and behaviors. This involves exploring situations that trigger alcohol use. And the goal is to identify and challenge unhelpful core beliefs and assumptions about oneself, others, and the world that translate in alcohol use disorder. For the management of care, we will reevaluate this patient in 2 weeks and assess for side effects, medical compliance, drinking behavior, psychological symptoms, and overall functioning. We will do this again monthly, and then we don't need to titrate. A compressate is pretty much a standard dose, unless there is kidney dysfunction, then we will half the dose for this patient if need be. For individuals who do not respond to initial pharmacological treatment, after 12 weeks, we will discontinue the first agent. Actually, we have 2 options. We can either discontinue the first agent and try subsequent trials of naltrexone or the sulfiran, and we can do that because a compressate is not addictive. It can be stopped suddenly and there won't be withdrawal symptoms. We could start with, or we can switch it to oral naltrexone that can be started at 50 milligrams per day. And or the other option is to start a second line agent in addition to the first one. And one of the second line agents that can be considered is baclofen, since this is not metabolized by the liver. So this was our case. Thank you.